It's like all we ever
it's
talk
the topic.
about.
Yeah.
Cottage cheese.
Oh, is that? Oh, no.
And like beef jerky. It's like all.
Beef jerky. Okay. Oh, these are desperate measures.
Welcome back to DocTalk, where we talk about the things we know you want to talk about with a doc. This is Dr. Janet Choi, Chief Medical Officer at Progyny. I'm Lissa Klein, and so excited that this week we have a very special guest, Dr. Samantha Dunham. Dr. Dunham runs the Center for Midlife and Menopause at NYU Langone Health here in New York, where we're based. Fun fact, she is my doctor. And we're going to talk today about menopause, perimenopause, all the things we know you are asking and want to know. And we are really excited to jump in. Dr. Choi is also recently a menopause certified, what is it?
Menopause Society certified practitioner.
Yes, so
Yes.
I'm surrounded by experts and I'm really excited to have a chat today. So we're going to jump right in. First, we want to talk about what is menopause. We know you already know the answer because we've talked about it before, and so we're going to drop in a clip right here.
Okay. So menopause, average age is somewhere around 50-51 for American women, although it can start, as we've seen over and over again, as early as sometimes for some young women in their 20s and 30s. It's when you get your very last period, but it's a retrospective definition because then you have to wait for 12 months and just have no period. And then if 12 months elapse since your last period, hooray, and I'll say hooray for some good reasons, if you're well supported, you're in menopause. In the years leading up to that final period, that perimenopause, which then extends to 1 year after your last period, can be years.
I would love to start to Dr. Dunham, and Dr. Choi, you feel free to jump in. Can family history affect menopause?
Oh, for sure. Yeah. Family history affects the timing of menopause, absolutely. So we know genetics plays a role. We also know that environmental circumstance plays a role in timing. Mm-hmm. Also, smoking plays a role when someone goes into menopause, if they've had a hysterectomy, like there's other factors. But family history is a big clue about when menopause might happen.
I remember when I saw you the first time, you asked me that question, and I didn't know when my mom had gone into menopause. But it's something that if people don't know and they're going to see a menopause doctor, they might want to get that information to share.
Yeah.
And what is the difference between menopause and perimenopause?
So perimenopause is that time leading up to having no period. So perimenopause can be a long time. It can be up to 10 years for some women. On average, it's around 4 years, maybe 7 years, but 4 would probably be a minimum. And it's the time when the menses become less regular. So at first they start to change in timing. So they might be a little closer together, they might be a little further apart. And then you just have the sense that the ovaries and the brain aren't communicating as well. So the periods aren't as predictable. After a certain point, maybe 2 years of that, people start to skip their cycles. And then they're into late perimenopause. So they'll skip for 2 months or 3 months. And that's a clue that the ovarian function is decreasing. And sometimes it's very gradual. Like people can track their cycles. Everyone has an app, they track their cycles. So they might notice instead of having that 30-day cycle, now they're having a 37-day cycle, or they're having a 24-day cycle. There's just some move in that shift.
2 points about perimenopause. What's really confusing, even to me as a doctor, is the straw criteria for perimenopause includes a first year after menopause, right?
Yeah.
So it's like that first year after menopause is perimenopause and it's postmenopause. The other thing is, and that's just nomenclature and wording, and who really cares? If you're going through it, you're going through it, and if you need help, you need help. But if you're on any kind of hormonal contraception, like the birth control pill, that can actually mask those menstrual cycle changes associated with perimenopause. So that's just something to keep in mind.
Exactly. Yeah. So that's the beauty of being on a contraceptive pill in the 40s is people don't have symptoms, and it masks that irregular bleeding.
If they are starting this transitory phase or starting this transition, should they see a doctor sort of immediately? How would you recommend people sort of manage this?
So I think it's really important to see somewhere in the transition to plug in with your primary care, because it's a time when metabolically things change, like cardiovascular risk increases. We know bone health changes. And other lipids changed dramatically in that perimenopause time. So it's really important to check in.
Yeah.
But if they're not having heavy bleeding, it's not an emergency. There's no emergency. I think for the sake of awareness, it's important to connect with the provider.
Yep. Estrogen is good for bone health, right? So as your body stops making estrogen, your bones aren't getting that valuable hormone.
Yes, it's really this incredible time. There's about a 5-year period around the time of menopause when the bones are always building and kind of destroying themselves. So, but during that time around menopause, there's just a destruction crew, where just taking apart the bone. So it's so important to know that's happening so you can support your bones through exercise, through weight-bearing exercise, through an adequate protein intake, through calcium intake, and vitamin D. Because it's just a big transition time. And once that bone's gone, there's really no great way to get it back.
Basically, my friends and I are all in our mid-40s, early to mid-40s, and all we talk about is how to get protein. It's all we ever talk about.
It's the topic, yeah.
Cottage cheese.
Oh, is that? Oh, no. That's not my favorite.
Yes. And beef jerky. It's
beef jerky, okay.
Canned salmon with the bones.
Yes.
So you get protein and you get calcium.
Oh, these are desperate measures.
Dark.
We're here talking about perimenopause and menopause, but for you, I have a question, Dr. Choi. During this time, is it possible to conceive if that is someone's goal, or accidentally conceive? How would you use birth control differently, or how would your attempts to conceive change during this time?
Again, I think if you have any ovarian function, so some menstrual cycle, even if it's irregular, there is always the possibility of getting pregnant, albeit at a very, very low rate. And even if you were to conceive, especially if you're going through perimenopause in your 40s, early 50s, because the health of those eggs is low since they've been sitting in your body for decades now, more likely than not, that pregnancy is not going to be a genetically healthy pregnancy. So if you do conceive, it's going to invariably, in many cases, end up in a miscarriage or a biochemical loss.
Right.
So if you're trying not to conceive, that's another reason why you should be talking to your primary care doctor. And if you don't like your conversations with them, then see someone like Dr. Dunham, where they can talk to you about options that help manage your symptoms, regularize your cycles, and keep you from getting pregnant inadvertently. Now, if you do want to get pregnant, that's a different conversation to have, ideally with a reproductive endocrinologist, and we have many great ones in our network. So they can talk to you about the most appropriate and safe options so that you end up having a healthy baby, because that's really the goal in that situation.
Yep. So let's talk through, sort of rapid fire, talk through some perimenopause and menopause symptoms, and understand what both of your thoughts are on them. So
Everything.
Everything.
It's everything. My husband being more annoying, that's a menopausal symptom, right?
Okay, first, this was one of the things I talked to Dr. Dunham about in our first consult, sleep troubles. People notice struggling to fall asleep and stay asleep.
Staying asleep.
So maybe what's causing that, and what are some lifestyle modifications people can do?
So the big issue is the wake up, the 2 a.m. wake up. People are wide awake for no reason at 2 a.m. Nothing's happened. They're up for 45 minutes. And we think it's due to hormonal change. We really don't know why it happens. It happens from night sweats too. There's vasomotor symptoms, so hot flashes and night sweats, those wake people up. And what you can do about it is, there's lots of sleep hygiene practice if that's happening. So that's a possibility. We do cognitive behavioral therapy for insomnia. That's the gold standard. But if people are waking up because of these hormonal changes, often you can use, if they're in perimenopause, the pill might help, the combination oral contraceptive, or we can use menopause hormone therapy, and that's one of the indirect benefits of menopause hormone therapy. It can really help with sleep.
Yep.
So menopause hormone therapy is both an estrogen and a progestogen. And the progestogen is often given as a medication called Prometrium, which is micronized progesterone.
Great soporific. It's just knocks me out.
It's like a hypnotic, practically.
Puts them to sleep.
Yes, right? Yes, yes. So you take it in bed because you're going to be asleep really quickly.
Right.
It's like the warm blanket of
Sounds
hormones.
delightful.
It's wonderful. And that helps people with falling asleep. and often the estrogen will help them stay asleep.
Okay, hot flashes. We talked about that a little bit. Mayo Clinic says that smoking, obesity, and race may be factors that increase the risk of hot flashes or flushes. Is that true, and any way to manage those symptoms?
Oh yeah, definitely, it is true. There's a big study going on. It's called the SWAN study. It's a study of the women across the nation in America, and they've looked at over 3,000 women and compared different ethnic and racial groups. And really, we've learned that so much of hot flashes and vasomotor symptoms are culturally based. So it's been fascinating. So so a lot of it comes from your environment, your education, your lifestyle. So and we learned that different groups have more severe symptoms and have longer time of symptoms. So like Black women will have symptoms for up to 10 years, Hispanic women around 8 years, white women around 7 years, and then Asian women, there's Japanese and Chinese women have less. So it really runs the gamut. Yeah. So there's a lot of cultural kind of background that informs how people either talk about symptoms or experience symptoms.
Change in sexual desire, so sometimes low libido. Is it curious, is that a hormonal shift, and is it related to vaginal dryness? Is it both?
So I mean, there's definitely hormonal shifts, and sometimes the other symptoms that can be happening, like mood changes, vasomotor symptoms. These are not things that put people, the libido goes to the background because there's other things that are just sleep disruption. And then also there's vaginal dryness. So there's something called genital urinary syndrome of menopause, where women can experience urinary frequency, urgency. They can feel very dry. Penetrative sex becomes very uncomfortable, and that just kills libido. So as soon as there's pain, libido and pain go like this. So they can't exist together.
Right.
So that's part of the story. But libido changes for women. For some, I mean, it might change for everybody. For some women, it goes from more spontaneous to more responsive. Some women have increase in libido. Some people don't notice any difference. It's really variable.
And would you recommend specific medications for that, or
CBT,
absolutely, that type of stuff?
Yeah. So it depends on what's happening. So if there's pain and there's vaginal dryness, then we use vaginal estrogen, which is different than systemic hormones. So vaginal estrogen can be used as a cream, as a tablet, as a suppository, and it really fixes, 90% of the time fixes the problem.
And actually also appropriate in certain cases in conversation with the oncologist with breast cancer survivors, right? Because the dose is so low.
Yeah, right. So there's really no increased risk for breast cancer or endometrial cancer. Even for breast cancer survivors, as long as they're not taking a certain medication, they're able to take vaginal estrogen.
Yeah.
That's great.
So it really opens the door for cancer survivors.
Over-the-counter vaginal moisturizers, vaginal lubricants may also, so vaginal lubricants ahead of actually having penetrative intercourse can decrease the vaginal pain, make it more comfortable, make it hopefully more enjoyable as well. And then just like I moisturize my skin every day, my face, my body, there are actually also vaginal moisturizers as well to try to help with that.
And those with hyaluronic acid are, I think, superior to others.
This was a symptom that I had, but also I think everyone has these days, brain fog and memory issues. I also noticed my attention span was shortening.
So it's super common, first of all, and the problems that people describe are usually verbal related problems, like verbal memory and verbal processing. And for most people, it gets better at some point, usually post-menopause, and we don't know why it happens. I mean, it happens because there's estrogen receptors in the brain, and the brain's affected as well. We know if people are having sleep disruptions, they're going to have issues with brain fog. We know if they have stress and anxiety, depression, that can affect brain fog. So there's other factors that come in, we talk about different ways to. It doesn't have a link to dementia, fortunately. So it's something that's passing.
And although I wouldn't necessarily, so hormone therapy has very key indications for its prescriptive use. So osteoporosis prevention, bone loss prevention, as well as moderate to severe hot flushes, night sweats. I found that one of the symptoms I had early on was a lot of brain fog. So I spoke to some of my colleagues, like Dr. Lobo, and decided to start myself on a very low-dose estrogen patch with Prometrium, and I found that estrogen really helped with the brain fog. Again, not a reason to start hormone therapy if that's the only symptom you have, but very useful.
Yeah, so for people who are low risk, it's worth a trial and to see if things have changed in 3 months and in 6 months.
Yeah.
So because if they do get the benefit, it's worth it. It carries you through that time without having that feeling of being lost.
Right.
I mean, I have patients who come in who think they're suffering from early Alzheimer's. You know, it's really
And it's
feels
terrifying.
like exactly. It really feels like cognitive impairment.
Yeah.
So so for a low risk person, it's an indirect benefit to hormones, and it's worth a trial.
Okay, weight changes. This happens to a lot of people. People report, like, as they move through their 30s and 40s, they start gaining weight. It's harder and harder to lose that weight if that's their goal. And so what is the hormonal impact on weight? And then what are some medications that doctors might prescribe if this is a concern?
Yeah. So weight gain is one of the number one complaints that people come in with because it's just insidious. You know, it's about 6 to 8 pounds over the course of perimenopause, and it gets harder to lose. And also the weight tends to be in the abdomen. So people develop a belly where they never had a belly before, and that links to, it's like the subcutaneous fat, but it links to the visceral fat, which becomes a health risk. There's no easy cure for it. You know, I mean, it's kind of going back to the basics of, really watching intake, making sure that your diet's clean, probably more heavy on protein than it's been in the past.
Cottage cheese.
Cottage cheese is coming back. And you have your salmon with bones here.
Yes.
Hormones aren't really a solution for weight gain. Hormones can help with where you put on the weight, so that it tends to be more in like the lower body than in the abdomen. And then medications, so hormones aren't prescribed for weight loss,
Right.
But the GLP-1 agonists are used now pretty commonly for weight loss, and they've been on the market for a couple of years.
From my understanding is all the fun stuff that are associated with menopausal changes includes also an increased risk for insulin resistance, adult onset diabetes, like type 2 diabetes, and in that way could muscle building, eating more protein, maintaining a healthy weight all contribute to trying to lower your risk of developing those issues.
So, I mean, there's sort of like a metabolic slowdown that happens. So we kind of need less calories, and at the same time, we develop this insulin resistance, so we don't process insulin as well. So it's really like we're kind of locked into a corner.
Right.
So all we can do is what you're talking about, is doing a little more exercise and trying to eat healthfully.
Less.
Yeah, eat a little bit less, but eat really healthfully. Make sure there's enough protein, enough variety. We heard a wonderful obesity specialist speak recently, and her motto was protein implants. So every snack, breakfast, lunch, dinner, you're thinking is protein implants. So I think that's the goal.
Besides Slim Jims, what are some other good protein options for
I think
vegetarians?
nuts are great.
Nuts?
Yeah, nuts
Tofu.
are great for protein. Tofu is great, right? Rice and beans. Cheese, and then I guess yogurts, right? These are what it comes back to.
Yep. The next on our list to talk about is bladder changes, and maybe this is related really to pelvic floor dysfunction or pelvic floor disorder, but during this time period, people might report that they're losing a little bit of urine when they sneeze or trip or laugh.
Yeah. So there often is.
I'm just laughing because I do, as you know, trapeze classes, and some of my female
That's pretty
classmates,
cool.
in order to get better and better, you're supposed to be doing trampoline work, which I hate. And some of my classmates are like, oh yeah, I don't like going on the trampoline because I have to basically wear a diaper when I jump up and down. And people don't understand why I'm running
Most
to the
people after
bathroom all the
childbirth
time,
are not
right?
going
I
on
know.
a trampoline.
Right. Yes.
Right.
So what can we do?
What can we
and
do?
actually, follow-up question to Alyssa's as you answer this, because all of this is super helpful to both to us and to our audience, is what percentage of your patients actually end up benefiting from pelvic physical therapy during this time as well?
So pelvic floor therapy comes up a lot with sexual dysfunction. So if somebody has pain with relations and they've had that experience, sometimes it's hard for them to re-engage. So we send people for pelvic floor therapy because they often have high tone in their pelvic floor, and they really need a physical therapist to work through it. It's like having, instead of a knot in their back, they have a knot in the pelvic floor muscles. So we use pelvic floor therapy for that. And also when people come in with bladder issues, usually the genital urinary syndrome of menopause presents urinary frequency urgency, just kind of dryness in general, maybe increased urinary tract infections, so they're getting recurrent urinary tract infections, And that's kind of what I think about for bladder-related issues.
Yeah.
And then the urinary incontinence, like there's stress incontinence. People cough and sneeze and they leak. And then some people have that urge incontinence where they're like almost at the bathroom, or they have their keys in the lock and then they have to go to the bathroom. It's an emergency. So there's all sorts of different issues.
Yep.
The pelvic floor comes into play with some of the stress incontinence, like with the trampoline work, like that's really challenging for a lot of women. And then they
Kegling and jumping at
you
the
can't
same
kegel
time,
and jump.
right?
No, you have to sit and think about the kegel. It's not an in motion exercise at all.
And then one other, we have a couple more symptoms to talk about. One is hair loss. Actually, after you put me on continuous OCPs, contraception pills, the person who cuts my hair noticed a lot of regrowth.
Oh, great.
Which is interesting,
Yes.
which makes sense. And so I hadn't noticed hair loss, but I think she did.
Okay.
Thanks, Jen. And she noticed some regrowth. So talk about like hair loss, why it happens, and what some things you can do for that.
Some of it is hormonal. People see there's changes like in the hair shaft, it gets thinner. But it depends on how the hair is being lost. And sometimes it requires dermatology workup. But for someone who's having, say, heavy bleeding, we know they might have low iron stores, and that affects hair growth too. So it's another reason to not tolerate heavy bleeding.
Yeah.
If someone's on the pill and they stop heavy bleeding, then they build their iron, their ferritin, and their iron resources. And then your body has a chance to shift that iron to the hair, because your body's not going to send that resource to the hair.
Interesting.
First line. I have to say that not every symptom happens to everyone.
Yes, by the way, but we're just trying to give you a whole laundry list so that if you're seeing someone who doesn't know as much as Dr. Dunham does, and you're like, I shared this symptom with them, and they said, oh, it's not menopause. That's why we want to list all of these for you, so you're aware that you're not making this up.
You're not going crazy.
No one's making it up.
Yeah. Mood changes and or onset of anxiety and depression that can happen during this time.
Yeah. It's a huge topic.
Yeah.
We see anxiety, we see depression, irritability, rage, like out of nowhere. And the symptoms can start really in the perimenopause. And sometimes it's the first thing where people just feel irritable for no reason. And it kind of mimics PMS. It's like an exaggerated PMS. And it's real. Their families notice it, the people notice it. Professional women come in and say, I can't believe I'm acting this way. It's like they're having out-of-body experiences. So mood is big. And hormones can help with mood. So especially if it's like PMS related, or it feels like PMS, kind of taking people off of those ups and downs and making their hormones more stable can help with the mood.
Anything we didn't cover that you think we should have, or anything your patients talk about that we didn't talk about today?
I think it's important to kind of look at the whole picture, right? So to think about building out your supports during this time. So you think about like your sleep. These are essentials. Your sleep, your exercise, your social supports. Long term, that's brain health, right? Having a variety of social connections. And that helps people manage this. And reaching out to people, because everyone's going through this. So, everybody has some experience with this. So I think it's important to establish your connections.
I think a lot of women are very used to multitasking, serving lots of other folks outside of themselves, and learning to draw some boundaries and saying, you know what, I need to really look out for myself. So I'm going to just say no to this project, or I'm going to just say no to my teenage son who needs to figure out for himself how to get groceries for himself, and figure it out so you have a little more space to not just deal with yourself, but try to kind of really focus on your well-being, because it's really, really important.
So if you haven't set boundaries, that's good. If you haven't set boundaries like that in your life, it's a good time to start. And if you don't know how, talk to support systems, talk to a therapist. I think especially for a lot of women at this age, they're in that sandwich where they're helping to take care maybe of elderly parents. They sometimes have families, partners, and so there's a lot that they are managing all at once. And having this change to their health and mental health can feel very overwhelming, so I think that's really good advice. And I think one of the most important parts of all of this is continuing to raise awareness, continuing to talk about it publicly, reduce the stigma. It happens to everybody, as I said, and so thank you very much for joining us today to be a part of that.
Thank you so much.
My goodness.
I think it's so helpful, and I think the more we talk about it, the more people feel comfortable talking about it.
Absolutely.
And so That's the answer to a lot of this.
If you don't have additional menopause support through your employer, I'm going to take over your lines, right?
Take it, yeah.
Speak up. It may be that your HR team does care, but they're just unaware.
Yep.
And so if you don't say something, you may be just jeopardizing your health as well as your colleagues' health. So speak up. Ask for the benefits. We have access to wonderful providers and coaching support to help you through this time that you shouldn't have to endure, but actually celebrate, in my opinion.
So thank you so much.
Thank you.
Thank you as always. I love doc talking with you guys. And as always, if you have things you would like us to doc talk about, drop a chat and we'll be sure to cover them in the future. We love doc talking with you. So thank you. Bye.
Bye.